One of the problems in compartment syndrome is that it's actually a tightening of the layer of tissue around the leg, and it's that causes the pressure to be high. Now, occasionally that's associated with some generalised tightness in the legs, such as tightness of the calf or tightness of the hamstrings, in which case physiotherapy can have some benefit, but it's the minority of cases that get better with physiotherapy, unfortunately. In the majority of cases you are actually looking at surgery. This tight layer of tissue, it's called the fascia, that goes around inside the leg. So you have the skin on the surface, then you have a thin layer of fat, sometimes more in some people, and then underneath that's the fascia that surrounds the muscles. Now that fascia itself needs dividing along its length. There's two types of compartment syndrome. You can get it as an emergency, usually after broken bones, when bleeding into the compartment causes swelling of the muscle, and that muscle can't swell because of the tightness. So in that situation it's an emergency because the bleeding leads to more tightness, more pressure, and eventually you're cutting off the circulation to the muscles themselves, and they die. That's a surgical emergency, you get rushed to theatre, and a slit's made in that fascia all the way from the knee down to the ankle. Now, as an emergency case, you do that by incising the whole length of the skin from knee to ankle, allowing the muscles to gape out. In the sports person, what you're actually getting is the muscles are swelling from exertion, so distance athletes, runners, they'll get it after a certain distance. This pressure will build up, so it becomes very painful. It's rather like having a stitch. The pain builds up and up inside the fascial sheath until the pressure is such that the muscles are cutting off their own blood supply. Now, fortunately, at that stage, a runner can stop, and has to stop, and the muscles can recover and the swelling goes down. Then usually, after a couple of minutes of rest, they can run on for a little bit longer, but not much. The problem is, again, it's the fascia. So that fascia is dividing all the way from the knee to the ankle. But because it's not an emergency, you can usually do that through two smaller incisions, two incisions of 2 or 3 centimetres each. But inside the leg, you divide the fascia along its whole length from knee to ankle, but on the surface it's just 2 small cuts, and it's done percutaneously by visualising inside. But it still causes surgical trauma from knee to ankle. It's still a bit swollen, a bit sore for a couple of weeks, but the incisions are relatively small. Normally the hospital will give you all the details you need. It's done under general anaesthetic, you're asleep for that, so we need to assess you preoperatively and make sure you're fit for that. Fortunately, this is an operation that's generally of fit, healthy people in the first place. There's generally very few worries about the anaesthetic. You need to let us know about any allergies or medical conditions you may have. The surgery itself can be done as a day case, but often it's a little sore to get up and about after the surgery. We like you to keep your legs elevated for a couple of days, so quite often we'll keep you in overnight, just for observation, make sure you're comfortable and mobile, particularly if it's both legs, and it is most commonly both legs that are affected. You go home the next day, rest for a couple of days. Now, time off work depends on your commute and what your work involves. People are in an office who can maybe get taxis or a lift to and from, are often off work only for a few days. People whose jobs involve a lot of standing, teachers, that sort of thing, they may be off work for a week or more. If obviously you can adapt things at the workplace you're working in an office, then you can get back a bit sooner than people who are, for example, doing a manual occupation. In terms of coming into hospital, you need to be prepared for surgery. It's nothing to eat or drink for 6 hours before surgery, except clear fluids like water, and nothing that will create stomach acids like milk or milky drinks. Other than that, you need to bring in normal medications that you take if you're taking any. Other than that, it's very little preparation of the actual leg itself. We'll worry about that afterwards. It's a matter of stretching. We divide the fascial sheath, but your body naturally tries to heal anything that's been divided, cut, torn. So the skin itself's healing, but inside the fascia is trying to heal. So during that process, you need to keep the muscles moving and stretched to stop it healing back together again. Recovery is variable. You're up walking the night of surgery. You're able to get around comfortably. Within 2 weeks or so, you're able to start non-impact exercise fairly rapidly on an exercise bike within 10 days to 2 weeks. Running, somewhere between 3 weeks, you can start generally on a treadmill, but it'll take you a long while to regain your former distances. Most people aren't back up doing beyond what they were doing before the surgery for at least 6 weeks. And after that, it depends on your level of fitness. These are often people who haven't been at their peak fitness for many months before going down the surgical route. So it's unsurprising it takes many months of recovery to get back up to marathon distances, for example. I normally quote people about 85% success. Now, success is variable. Some people are completely cured so they can get back to full level marathon distances. Other people are improved significantly so they get back to running but still get some problems. The reasons for that is that the tightening process that affects the fascia often affects the muscle itself, the divisions within the muscle. So if you do have tightness in the muscle itself, it's often difficult to get back to your full distances. Some people, the fascia does heal up, which is why we're keen on the stretching regime. I actually, over the last 3 years, have used a variant of the technique where you divide the tissue not only along its length, but a little what they call cruciform extension towards the tibia. And that seems to have improved the success rate of people. And it's probably about 90% of people are dramatically improved. Technically, it's not that difficult. Most orthopaedic surgeons will have done it for an emergency scenario, a sort of big slash from knee to ankle, doing it through smaller incisions for sports athletes. It's not technically difficult. The difficulty is in recognising those people who need it. There are many different causes of, we generically call them exercise-induced leg pain. It can be pain coming from the back, it can be compartment syndrome, it can be medial tibial stress syndrome. I think when we last counted up in our sports clinic, we'd seen 28 different presentations, different diagnoses of people with very similar sounding leg pains. So it's a matter of selecting the group that have the right diagnosis, and it's not just the test in isolation that proves it, it's taking a test into account with all the other clinical information, because don't forget this condition is common and therefore can coexist with other problems. And often when you get athletes up at the highest level of performance, it takes very little to tip them over the edge from being a high level elite performance athlete to somebody who can't do what they want. And so having a holistic view of their pains, what they need, is actually rarer. It's often an operation done on athletes. It's not exclusively that. Some people can get this condition. I've operated on people who are politely pretty much out of shape, who have similar pains. But again, it's a matter of picking out those that would benefit from the surgery, those who there may be an element of it. But other than the medical conditions precluding anaesthetic, no, pretty much anyone can have it who needs it.